Thanks everyone, and yeah, from my side, interesting stuff. The last 2 weeks has been coming at us as a deluge of information. I wonder if they were talking to each other about the bulls and the health market inquiry all coming out at pretty much the same time. But let's not get into that. So this thing doesn't push ahead. Okay, I can just run it. On my. Yeah, I like to wander around a bit, so that's why I'm wearing the sci-fi stuff instead of over here. But anyway, okay. So I thought about let's see what we'll have a look at today. Just an introduction around where we are. Some things I'd like to debunk a few myths that, especially the minister likes to just throw out there as absolute fact. Really, some of them are just simply completely untrue. Others a bit of a stretch, but we'll go through that. What's actually being proposed? Let's look at how they're trying to piece it all. I mean, Evan also touched on it, like trying to piece it all together. Some of it's still very unclear. And then let's have a look at the LCBO itself. So I think one of the things is just a question of why is healthcare so important, and I think it's an important point to push. It's a very emotional thing, you know. I mean, to everyone buying healthcare, it's personal. It's an important thing, and the reason I emphasize this point is that it's a powerful political tool, and one that can really be subject to a lot of abuse, and through this misinformation or disinformation or outrageous lies, if you like, in some cases. So I think it's important that we interrogate the facts and have a look at it at that perspective, rather than running down this road of rhetoric, which seems to be the mainstream of the information that comes out. So before we go into, did I get ahead of myself there? Sorry, maybe I'm like the Minister of Health, getting ahead of myself a bit, you know. Anyway, okay, so let's have a look at what the basis of the NHI is. The private sector spends approximately 4.4% of GDP in the private sector, mainly through medical scheme contributions. The public sector, on the other hand, about 4.1%, so roughly equal. And yes, there is a massive difference in the number of lives that they service. But the proposal from NHI, and this is really in a nutshell, is take the money from both sides, chuck it into one pot, and then we've got 8.5% GDP to spend on everybody, and everything will be hunky-dory. Great, okay. But the real problem with all of that is that all of the money that comes out of here is 100% tax funded. But all of the money that comes out of here is privately funded. There are some tax rebates to that, which I'll touch a bit now. So effectively, these people here are funding everything in any case. Okay, so it's interesting to have a look at it in a different way. So let's start on the myths. So let's have a look at this here. Universal health coverage equals NHI. So the only way you can get a universal health coverage is you have to have a national health system. Okay, that's a point I really need to look at. Universal health coverage is a policy objective. Okay, that's one aspect. So yes, you want everyone to have access to a certain basic package, and that's a laudable objective. But what is NHI? It's not a policy objective. NHI is a funding and delivery mechanism, and there are alternatives that can be looked at. Medical schemes are alternatives. Primary care products, LCBO, could be an alternative to it. It doesn't have to go through this national fund. The national fund makes me shiver a bit because the possible implications, but I just think those two need to be separated. The minister talks about NHIs, it's the only way in which you can achieve universal health coverage, and I don't think I certainly know that's not true. Let's look at myth number 2. I've got a few slides on this one here. This one drove me nuts when I read it. But anyway, the private sector is heavily subsidized by the public sector. I'm not quite sure how that all comes about. But anyway, let's have a look at it. So what's the button? There we go. Okay, medical scheme tax deduction was what we had a few years ago, and that was moved to a tax credit in 2012 to 2013. So I have a look at the numbers there. So I'd say prior to when it was a medical scheme tax deduction, there was quite a significant tax advantage in contributions to medical schemes. So there I'd say there was a reasonably heavy subsidy. And when they converted to a tax credit, it was to say, let's give everybody the same tax advantage regardless of whether you're on a top-end option or on a bottom-end option, which I think is the right way to go to make it equal. But they didn't take the 64 billion and spread it. They substantially reduced the tax relief that was given down to less than a quarter of what it was in the previous year. So that was a massive change and quite silent. We didn't really realize until only once we did the numbers about a year later, we started to realize, hang on a minute, it didn't quite pan out. So each year the tax credits were increased. So on the last available data that I've got, 2016 was about a 18 billion rand deduction. But let's look at what are the contributions to medical schemes. 164 billion in the 2016 year. I hope my figures are right, Evan. I think it's about there. So the tax deduction is slightly more than 10%. So we're not looking at a massive component of what is paid here as pre-tax. In fact, about 88% is pre-tax. It's paid with after-tax money. So there's no heavy subsidy from of the private sector by the public sector. Still on myth number 2, state sector employees receive subsidies from their employer, the government, of about 30 million. But that doesn't subsidize the private sector, that's subsidizing the public sector. It's actually affect a cost to taxpayers. Okay, so I don't think you can argue that that money is subsidizing the private sector, because if that subsidy wasn't there, it would be a lower cost to taxpayers. Okay, that's the way I would look at it. Yes, and yeah, the last point here. I don't think the unions are going to give up this too easily. I saw last week that all of a sudden the unions are now backing NHR, when previously they said they weren't going to back it. So I don't know what's going on in the background. But when it comes down to them losing medical scheme membership and losing that subsidy, I don't see these guys lying down without a fight. Still on that, all medical services are subject to VAT. Public sector services are not subject to VAT. Okay, so again, an implicit subsidy between the two from one to the other. And then let's have a look at this over here. State tenders for private consumables, things like medicines, things like your consumable items that are purchased by the public sector from private suppliers. They drive those prices down through very tight tender processes, so that it becomes very competitive to get those. But the lost margins are then recouped where? The private sector. Okay, so again, it's an implicit subsidy, very silent, this one, from the private sector to the public sector. So anyway, I just wanted to debunk that myth, because that one really just got to me, because it's totally untrue. Okay, so let's look at number 3. Public sector is underfunded. Okay, so what I did is I thought, let's kind of have a look at a few numbers here. I got this from World Health Organization. It goes back 2013, so that's quite a few years. Obviously, the World Health Organization's report is a bit delayed because of the magnitude of all the data they put together. So in South Africa, the total expenditure per capita was $530, all based in US dollars, of which the public sector is 343. Okay. Now I didn't have the breakdown, unfortunately, of the split between private and public on the other countries. But let's just have a look at it, considering that this spend over here, which is total per country, must constitute some private spend and public spend. So therefore, public spend only must be less than these figures. So if we look at the red ones, which I've just highlighted in the arrows, look how South Africa compares to its peer countries. It's not way out. Okay, I mean, if you take a country like India, it's significantly lower health budget than what South Africa has. So I would argue that we're just not spending this very well. And I don't think anyone tell me that we are spending that well. I mean, given the state of the public health sector, I mean, so there's enough money to go around. I think the issue here is that it's not being spent properly in terms of mismanagement, corruption, all of these things. That we're not getting the outcomes we should be getting out of that spend over there. Okay, so that's just my one point I wanted to make there. The other one is that the cost of NHR is not important. Okay, it doesn't matter. It's like willy-nilly. It's only the biggest thing that South Africa has ever done in terms of a single item of expenditure. But yet the minister is saying it's not important. Although I've subsequently heard he's actually said, not that it's important, but it's the figures are a thumbsuck. Am I correct in that? I think he did. So it's been hard to keep up with the last 2 weeks because all the press coming out. But let's have a look at some of the numbers. So Economics did an analysis 2 years ago, and they worked out that there'd be a 200 billion rand shortfall on the white paper numbers. But now remember, the white paper numbers were in 2010 prices. Okay, that's quite a long time ago. If we extrapolate that forward a little bit, we're looking at 400 billion rand as a possible shortfall if Economics numbers are correct. I mean, just consider what tax collections were last financial year. I think we were about 1.2 trillion. I mean, to me, it's just not feasible. Consider that not this last budget, but the previous one, Treasury were scrambling to find an additional 28 billion to balance the books. So I mean, where they're going to find a number like that, it's just, to me, it's totally unfeasible. So the funding is possibly the most important factor around NHI, and I think from our point of view, we need to say to government, you cannot ignore that, because it could have a massive impact on the economy, detrimental to the economy rather than positive. Okay, so let's have a look at what's being proposed. Okay, so it was suddenly jumped at us. 2 bills, Medical Schemes Amendment Bill. It was actually signed a few weeks ago, but the Minister of Health held on to it because he wanted this signed first before he would release the two. So he released them together, which I think is probably the right thing to do. And they talk to each other a little bit. I don't think as much as what he's made out to be, but there are obviously elements that talk to each other. And then, as I say, the timing of the last few weeks has been interesting, because then suddenly the health market inquiry came out as well, and a lot of stuff in there that may not talk to exactly what's in there. But anyway, we'll get into that. So let's have a look at exactly what's being proposed. So funding, benefits, delivery, those are really your 3 components of a health system. In the NHI fund, we've got the NHI fund which is being proposed, which will be the purchaser and provider of healthcare for the NHI, and the existence of medical schemes they're not being done away with. They will still exist according to these bills. The differences are that the NHI fund will finance a package of NHI benefits yet to be defined, but it's stated as a comprehensive set of benefits. We don't, at no stage is really any analysis or any work been done on what that is, but we understand it to be a comprehensive set. And the key issue on medical schemes is that they'll only be able to finance supplementary cover. In other words, whatever the NHI doesn't fund, that's medical schemes will be excluded. And I don't think that's changed from the green paper and the white paper. That's kind of how it was seen, and they're carrying that through in these 2 bills. But the slight difference, well, not difference, but an interesting aspect here is that the NHI is then going to be looking at purchasing from both private and public sector service providers. Okay, and that's also been fairly consistent in terms of through the papers, considering that because of the supplementary cover structure, so what the private sector is currently providing for may well fall away and fall into this. So it will force the private sector to purchase or to receive a revenue from the NHI fund and actually deliver services through that, because some of the business here may well, in terms of this proposal, will fall away. And I've also presumed that whatever the supplementary cover was through medical schemes, that they would only purchase it from the private sector. They may well purchase from public, but I don't think so. I think it will really come from private. So that's the kind of picture that I see of how the proposal is being put together. And some of the aspects of it are, I touched on a few points here. So there'll be accreditation by the Office of Health's Health Standards Compliance, is that the right acronym? Yeah. Of all providers, both private and public, who deliver services to the NHI. So if a private provider says, we're not going to deal with the NHI, that's fine, but if you do, then you have to meet the standards set by that office. I got ahead of myself again. Private and public, yeah, okay. I sound like the minister again. Okay, and there'll be fixed tariffs and fees. So the NHI fund will set what the fee is for every item of service. I'm sure for the doctors in the room, you feel great about those kinds of proposals, depending on how they go about it. Is it going to be a transparent process? Is it going to be fair? Is it going to be reasonable? Will it actually reflect the cost of delivering the care? And then the issue I pointed out earlier, there's a difference between the public and private in terms of VAT, because public sector services are not not subject to VAT, whereas the private sector is. So are they going to take that into account, or do they have to compete at a price disadvantage of 15%? And presumably then citizens will be allocated a doctor, ostensibly a GP. So if you're in an area, you have to be part of the NHI, and for those services or benefits, this is your doctor. Okay, because the proposal very much is that it will be a GP referral system, so you won't be able to access higher levels of secondary or tertiary care until you've gone through your GP. Okay, almost like a network structure of a medical scheme. I think some people might feel aggrieved about being told where to go and what to do and how to access healthcare. So that's pretty much the proposal as it stands in those 2 bills. So let's have a look at LCBO, and obviously why we're here today, to have a few discussions. That was the background of stuff, the context. So the interesting thing for me is this, that the bill contains no provision for LCBO. It's not specifically saying we're making a provision for it. There's a clause in the bill that says that the minister or the regulator, the Council for Medical Schemes, can reduce benefits of a medical scheme in consultation with the minister, but that's to avoid overlap of benefits that the NHR is providing. It's not saying LCBO. It's talking about that comprehensive minimum package, which Evan touched on in one of the questions, and I agree with him. We're still expecting it to be at a relatively comprehensive level, that R1,000 a month per family. So I wonder why they didn't take the opportunity. If this LCBO is in the pipeline, why not put it into the bill? You're putting in a bill, so it has to go through the whole parliamentary process. So I'm not following as to why they didn't do that. If they're intending to get LCBO going, it would have made sense to me, unless they've got some other magical idea. So as I say, because the NHR bill contains that comprehensive benefit set, why not? How are they going to implement this? So my questions to that would be, are they still going to rely on Section 8H of the Medical Schemes Act, which allows the registrar to exempt schemes from meeting certain criteria? So like the PMBs, there are about, I think, 4 schemes at the moment that are exempt. I don't know, even if you have any. It's about 4 of. It's a handful. But to implement LCBO under this, I've spoken to some of the legal minds who have opinion on this. They're saying it's rather dubious, because LCBO would be an industry-wide issue that almost all schemes could do. Because this clause in the Act says that only under exceptional circumstances can you provide exemption. So an industry-wide LCBO, would that be exceptional circumstances? So the question would be, can Council for Medical Schemes implement LCBO under this clause 8H? Or should it have been done via the Medical Scheme Amendment Bill? So those are the kind of questions that I would put there. If it goes via the exemption, how do you feel about it? From a point of view of being an insurer that's providing primary care that would ultimately go into an LCBO in a scheme. And then I think something that's also been raised in the previous questions or discussion is, Jason, as you say, will they just kick the can down the road? And will they extend it? I think from what we've heard behind the scenes now, it's likely that they're going to extend this current exemption period. I mean, it's less than a year, and I think all the insurers, we've just submitted the data that says this is what we've got, the detailed information. So they're still going to have to chew on that. I think it's quite a lot. There's 30 odd exempted insurers. So and I think the council's got a lot of work to do with all sorts of other stuff as well at the same time. So these are the kind of questions that I would have there. The questions for an insurer is, what is an LCBO? How do you retain interest in an LCBO world? Could be quite difficult. Is it through the provision of care or the funding of care? Currently you're funding. I don't know, some of you might be providing as well if you have your own networks of providers. But if you're only funding, is it possible? Because now the premiums have to flow through a medical scheme. So, and then, can insurers continue under the exemption? What will these conditions be? So is the exemption going to change after all the data has been collated? Are your terms and conditions going to differ from the letter that came out, I think it was last year, October, which gave the immediate and continuous clauses? Some of them were quite interesting. How do you immediately and continuously comply with something that you've only just been told to comply with? So from our side, those are a few questions, a few others here. In terms of the bill not addressing LCBO, are the poor being ignored again? Should we raise those questions? I mean, should it just be up to the regulator to implement? As Evan outlined, depending on how it's done and where it's set, there could be substantial implications. I mean, I think for most of you in the room, you're here because of a market failure, and you filled a gap to provide healthcare to those people who can't afford medical scheme cover. So again, is this a valid question? Again, will LCBO ignore it because of NHR? Because NHR has been about the only thing that's been discussed around healthcare for the last 10 years. Not much other discussion has really happened. So again, because my sense here is that the private sector has been largely ignored for the last 10 years. The Medical Schemes Amendment Bill is the first piece of proposed legislation of really any substance that we've seen in that time. So I just wonder about the attention that's going to be given to that in terms of NHI and Medical Schemes Amendment Bill sucking up all the bandwidth in terms of government's time and efforts. Anyway, but thank you very much for listening. I appreciate your time. And